Okay, let's start. Micaela, I will. Hello, everyone. Welcome to join us for the last presentation of this semester. And thanks again for all your support for this semester. And best luck for your exams in the coming weeks. And so as usual, for the presentation, we will have about 45 minutes presentation. At the end, you will have question sessions. You can ask questions. If you have any questions, I would encourage you turn on the camera, but you always have the options to type the question in the chat box, and I will read that, and so everyone can know. Okay, so today we have great pleasure to have Dr. Micaela Karlsen here, and so Micaela, she actually, I just want to say first, she also graduated from here. She had a PhD, complete the PhD program in the former NICE program, the nutrition epidemiology program. So, and now she's a senior director of research at the American College of Lifestyle Medicine. She's also adjunct faculty for the University of New England master's program in the applied nutrition and global public health. Dr. Karlsen is the author of A Plant-Based Life, and she also contributed to the New York Times, the bestseller book for Forks Over Knives. And I remember a long time ago we watched the documentary for that film, so it's very nice. If you haven't seen that, I will encourage you to watch that documentary. And Dr. Karlsen has expertise in dietary patterns, plant-based nutrition, and nutrition adequacy, and lifestyle medicine. And she holds a PhD, like I just said, from our nutrition epidemiology program. And she also had master degree from Johns Hopkins School of Public Health. So for today, she will present her experience on the lifestyle medicine, and that's a very important topic, and looking forward to your talk. So please take away. Okay.
Thank you so much, Dr. Ma, and thank you to the Friedman School for hosting me. It's really an honor and such a pleasure to be here, since I'm an alum of the Friedman School. I had a wonderful experience here getting my PhD under Dr. Nicola McCune. And now I'm really happy to report that I've sort of transitioned a bit into the field of healthcare, and specifically lifestyle medicine. And I'm really looking forward to this talk today on the intersection of healthcare, nutrition research, and public health. So the objectives I wanted to dive into today are quickly, because I know this isn't new, just review the problem of the healthcare crisis that we're facing, and really discuss the field of public health as it relates to healthcare. They're kind of two almost unnecessarily separate spheres, and there are a lot of ways I think we can bridge that gap a little bit more closely. We'll talk about lifestyle guidance as it currently exists in clinical practice guidelines, and then define and introduce the field of lifestyle medicine, and discuss some connections and the overlap between lifestyle medicine, public health, and nutrition research. And finally, just conclude with some comments about the gaps and opportunities for translation of public health research into healthcare. I really hope that a lot of the students watching this today will feel inspired to explore lifestyle medicine as an aspect of the work that you go into in the future, either if you're going into research or clinical care or policy or education. There's a lot to do, and I think this is one path that can really help us achieve together, the direction that we all want to go in, which is have a healthy nation and a healthy world. So we know that we're facing a healthcare crisis, and chronic disease prevalence is at an all-time high. We have 6 in 10 adults in the US with a chronic disease, and 4 in 10 adults have 2 or more chronic diseases, cardiometabolic diseases, chronic kidney disease, cancer. We know from the Global Burden of Disease report on the population intake of 15 foods and nutrients for adults across 195 countries that dietary factors accounted for 11 million deaths in 2017 from non-communicable disease and 25 million disability-adjusted life years. And they were able to conclude that suboptimal diet is responsible for more deaths globally than any other risks, including tobacco smoking. So we know that it's a global problem. The impact of health behaviors and particularly diet is very substantial, and things are only getting worse. Of course, our health outcomes and even our health behaviors are more complex than individual decisions or individual health behaviors. I really like this conceptual model from the University of Wisconsin Public Health Initiative, their county health rankings initiative. They have outlined really the complex dynamics that go into our eventual health outcomes of length of life and quality of life. It's a broad list. We have health behaviors, clinical care, social and economic factors, and the built environment. And together, all of this has an influence on health outcomes. And mortality and morbidity have many points of influence here. The field of public health takes a broad approach. The field of medical care and healthcare often takes a more pointed, narrow, or sometimes reductionist approach. And researchers in nutrition, physical activity, sleep medicine, and other areas of health behavior may fall anywhere on that spectrum. So there are many points at which you can intervene and many points at which you can gather important information to inform the big picture of what leads to the eventual outcomes. We know that in the US, almost no Americans lead a healthy lifestyle. So a 2016 analysis of 2003 to 2006 and Haynes data found that only 2.7 of individuals had a healthy lifestyle, and they defined this with 4 factors: meeting physical activity guidelines, a diet score in the top 40% on the healthy eating index, a body fat percentage under 20 for men or 30 for women, and not smoking. And it's worth mentioning that this was a drop from the previous analysis of this kind, looking at almost the same 4 healthy behaviors. In 1994, 6.8% of Americans would be considered living a healthy lifestyle. So since 2006, of course, we know that obesity has continued to climb and chronic disease rates are not dropping. So we have a big problem, not only in terms of our built environment and our sedentary jobs and our all of the factors that sort of contribute to these health outcomes, but even just some basics here, we really have a concerning situation. And of course, this translates to the cost of chronic and mental health conditions. So 90% of the nation's $4.1 trillion in annual healthcare expenditures are for people with chronic and mental health conditions, which is a lot of money. And the financial viability of this is definitely in question as things continue to progress and advance. It's also worth mentioning that the US has the highest rate of healthcare spending of any OECD nation. We're an outlier. The black line on the top is the United States. We spend about 18% of our GDP on healthcare, and what we get in return is disappointing. We have the highest rate of avoidable deaths of any OECD country. So the US, again, is that top black line on the right-hand side. We've had the highest avoidable deaths per 100,000 since about 2004. And now there's a bigger gap than previously, and it's continuing to climb. It's also worth mentioning that life expectancy in the US dropped for the 2nd year in a row in 2021. This is a press release from August from the CDC, and this life expectancy drop is very related to COVID-19. And we know that the risk for complications and mortality among people who were infected with COVID-19 was much higher among those with comorbidities like type 2 diabetes, cardiovascular disease, and obesity, all of which are driven by lifestyle factors. So, of course, we have some very good systems in place to try to address this, all of these issues in the field of public health. We, implement a public health approach, and there are various different sciences that compose the overall field of public health. So surveillance is used to monitor public health situations such as COVID-19, but also chronic diseases and non-communicable diseases. Epidemiology enables us to determine where diseases originate, how or why they move through populations, and how we can prevent them. And nutritional epidemiology is the study of that as it relates to food, as many of you are involved in. Public health laboratories support public health by performing tests to confirm disease diagnoses, and they also conduct research and training. And then as we move away from paper records, public health informatics continues to increase in importance. That deals with the methods for handling and managing data electronically. And as we, in the future, continue to develop and improve the sharing of electronic medical record data, I would anticipate that those two systems would be more and more closely combined, although there are a lot of logistical challenges with that prevent that from being a very smooth process just yet. Then prevention effectiveness is closely linked to public health policy. It provides important economic information for decision makers to help them choose the best available option. So together, these core sciences kind of make up public health. And if we think about nutrition and health sciences research, they really can be involved in a lot of different points of entry in this system, and also inform, or at least ideally inform directly, health policy, clinical practice, and reimbursement. In reality, a lot of times the effect of research and findings from research is disappointing when it comes to policy. That's not always the case, but there are a lot of politics involved, even a lot of personal dynamics involved from lawmakers. But we can do our best, and many policy documents are very much informed by research, and it's certainly our best effort and our best path forward to make sure that the information that we can share with decision makers is evidence-based and grounded in the kinds of outcomes that we want to see happen. So looking at prevention effectiveness, again, this is from public health, assessing the impact of prevention policies, programs, and practices, evaluating the allocation of healthcare resources, and then providing decision makers with information for action. And you can break this apart a little bit more. There are some various different steps in developing and implementing prevention strategies. So first, we have basic research. Is prevention plausible? Is it biologically plausible? Has it been seen to happen? Applied research, this is efficacy, can prevention work? Is it possible in people? Community demonstrations, is it effective? Does prevention work in a real life setting? And then implementation, is it continuing to work? And again, here, nutrition and health sciences research outside of the field of public health are really closely tied to those first three, and to a lesser extent, the fourth one. So thinking about public health prevention, we have three levels: primary, secondary, and tertiary. Primary means intervening before health effects occur through measures like vaccinations, altering risky behaviors, and banning substances known to be associated with a disease or health condition. And this is where a lot of nutrition research and health behavior research kind of exists, in this place of primary prevention and reducing risk over time with the hope of eventually improving mortality and morbidity in older age. Then we have secondary prevention, screening to identify diseases in the earliest stages before the onset of signs and symptoms through measures like mammography, regular blood pressure testing, all of the screenings and assessments that happen not only in population health programs, but also in your doctor's office. Then we have tertiary prevention, which is really focused on managing disease post-diagnosis to slow or stop disease progression through measures such as chemotherapy, rehabilitation, and screening for complications. So I would like to, and then this is a really nice graphic to kind of show all the points of influence in the spectrum of prevention. We have policy and legislation, the built environment in neighborhoods and communities, coalitions and social networks, internal practices and policies of agencies and institutions, educating healthcare providers and other professionals, promoting community education, and then strengthening individual knowledge and skills, leading hopefully to better individual decisions and better self-efficacy. So we have public health prevention, and then we have healthcare, which ostensibly is meant to treat disease and to help people become well when they're sick. I think that in practice, some of the problems that we are facing come from the fact that conventional practice of medicine really focuses in some ways on secondary and tertiary prevention, but much less so on treating the root causes of disease and helping people achieve wellness and well-being. So we have a lot of strengths in secondary prevention and tertiary prevention in the Western world in our healthcare system. One of the best strengths of allopathic medicine and our current healthcare system is diagnosis and screening. If you have symptoms and disease, like there's no better place to be in the world than the United States to find out what's going on. Where things start to fall apart is that the tertiary prevention kind of, for chronic disease anyway, kind of stops at management and doesn't really usually address treatment to achieve well-being. And I also, this could be a completely different talk, but I'll mention that this is relatively frustrating for healthcare practitioners and physicians who went into medicine probably to become true healers. And we have a lot of research now around rates of burnout and the frustration that comes from the depersonalization, the lack of professional satisfaction, and the overwhelm and workload that sort of goes along with conventional medical practice. So even though we have sort of touched on the public health framework for thinking about chronic disease, and like it's very well known that health behaviors lead to better health outcomes in individuals, let's also take a look at the current lifestyle recommendations in medicine. So do they translate into official guidance? And they do. So lifestyle change as a first line of defense is included in many clinical guidelines, which is very encouraging. Many clinical practice guidelines state that diet and physical activity changes are a critical first line for prevention and treatment for many chronic conditions like diabetes, obesity, hypertension, and often should be incorporated before medication is prescribed. And this is reinforced by a lot of leading national organizations, and we'll go over a few examples. So the American Institute for Cancer Research, so I'll first look at a couple recommendations for prevention, has their blueprint to beat cancer, and they identify eating a diet rich in unrefined plant foods, limiting red and processed meat, limiting fast food and foods high in fat, starches, and sugars, being a healthy weight, being physically active, limiting sugar-sweetened beverages, limiting alcohol, and focusing on food as opposed to supplements for cancer prevention. So this is a very comprehensive and very clear set of recommendations. We also have the U.S. Preventive Services Task Force. They have a set of recommendations for behavioral counseling interventions to promote a healthy diet and physical activity for cardiovascular disease prevention in adults without current cardiovascular disease. So that focuses on dietary counseling, physical activity counseling, interventions individually or in groups, and they talk about typical counseling techniques and interaction time, which is kind of a critical thing to think about in terms of how that can happen in healthcare, range from 30 minutes to 6 hours over 6 months or longer. So we have, several great recommendations for prevention, and then now let's look at some for treatment. The ADA has their updated standards in diabetes care, the section that relates to lifestyles and the prevention or delay of type 2 diabetes and associated comorbidities. So this is for treatment of prediabetes with the hope of preventing it from advancing to full diabetes. And they really are emphasizing lifestyle here. We also have the Joint National Committee, JNC 8 guidelines for hypertension. They suggest implementing lifestyle modifications in all adults over age 18 with hypertension. And lifestyle changes they identify are smoking cessation, controlled blood glucose and blood lipids, diet, healthy diet, moderate alcohol consumption, physical activity. They really have incorporated that even in their algorithm before the rest of the treatment process. The 2020 International Society of Hypertension Global Hypertension Practice Guidelines identifies lifestyle advice immediately following a diagnosis. This is also something very clear that should be incorporated prior to deciding which path of medications to follow. And the 2019 report from the American College of Cardiology and American Heart Association Task Force also suggests lifestyle to prevent or reduce risk and encouraging lifestyle, healthy lifestyle for lifetime risk, and also a discussion of lifestyle to reduce risk factors. So we have a lot of consistency across different organizations. The American Association of Clinical Endocrinology has their type 2 diabetes management algorithm. So they state that lifestyle optimization is essential for all patients with diabetes. And it's a multifaceted, ongoing approach to engage the entire diabetes team. However, such efforts should not delay needed pharmacotherapy in higher risk individuals. So again, it's not an approach to only use lifestyle, but rather to incorporate lifestyle as a first-line treatment as part of care. And you can see their algorithm and their practice pathway really identifies nutrition, physical activity, sleep, behavioral support, and smoking cessation as all as important factors that can lead to reduced risk and reduced burden of complications of obesity. ACE also has a consensus statement that is a joint consensus statement with the American College of Endocrinology, and they again emphasize lifestyle optimization is essential for all patients with diabetes. And our own organization, the American College of Lifestyle Medicine, published an expert consensus statement, which was ultimately endorsed by 3 of the collaborating organizations that worked with us, American Association of Clinical Endocrinology, Academy of Nutrition and Dietetics, and the Endocrine Society. And this statement was on dietary interventions to treat type 2 diabetes in adults with a goal of remission. And the panel agreed, they found consensus using the Delphi method on a lot of statements. I'm just showing a few here as an example. These include diet as a primary intervention for type 2 diabetes can achieve remission in many adults with type 2 diabetes. Diet is the cornerstone for managing type 2 diabetes and can be used in combination with medical therapy for achieving remission of T2D. Medical therapy must be accompanied by dietary intervention for achieving remission of T2D. And the intensity of a dietary intervention for T2D is determined by the degree of dietary restrictions imposed and the frequency and duration of patient contact or counseling. So again, the theme of patient contact and the amount of contact time is coming up when it comes to health behavior change and behavioral medicine. We also published a study just a few weeks ago in Advances in Nutrition, and I can thank Micaela for her involvement as project lead and first author on this paper. This was a meta-epidemiological study on commonalities among dietary recommendations for the last 10 years. So the primary objective of this research was to compare dietary recommendations from CPGs that were developed by major organizations aimed at promoting general health or aiming to improve or treat health for adults with pre-specified chronic diseases, and that included cardiovascular disease, diabetes, cancer, autoimmune diseases, COPD, digestive diseases, and weight-related conditions. So we had 78 included studies, 78 included clinical practice guidelines, and 83% were from major medical professional societies, 12% were from governments, and 5% were other large stakeholder organizations. And we looked for recommendations related to overall dietary patterns, major food groups, and food components frequently addressed in research and clinical settings like salt, saturated fat, protein, or sugar. And so overall, 83% of guidelines made food group recommendations, and these were categorized as either include or increase, like they encouraged intake, or exclude, decrease, limit, meaning they discouraged intake. And we analyzed 15 food groups, and the graphic for that is displayed here. And our top encouraged food groups, unsurprisingly, were vegetables, 74%, fruit, 69%, whole grains, 58%, legumes and pulses, 47%, any nuts and seeds, 44%, low-fat dairy, 38%, and any fish or seafood, 36%. And our most discouraged food groups were red meat at 32%, processed meat at 27%, refined grains at 19%, and fatty meat, 12% of guidelines discouraged the consumption of fatty meat. So overall, this is a relatively consistent set of messages and guidelines, and it was very satisfying to see this because, of course, we know there's a lot of confusion in the media among consumers about what they should and should not be eating. And overall, globally, major health and medical professional organizations do agree, what should be encouraged and also avoided. And remember, the included papers in the study were clinical practice guidelines. So for many of them, nutrition, lifestyle was really not the focus of the guideline, but they were included, and that's really quite a big set of guidelines in practice to have. So, okay, in spite of all this consistent messaging and the inclusion in clinical practice guidelines, instead of handing people nutrition prescriptions and physical activity prescriptions, most patients are first treated with pills and procedures, and this is an ongoing problem. It leads to a lot of dissatisfaction on the part of patients and quality of life, and it also leads to a lot of cost, as we talked about. And so lifestyle as a first-line treatment is not yet the standard of care, and there are a few very clear reasons for why that is. There are very brief appointments with a doctor, usually less than 15 minutes. The fee-for-service model that most physicians and practices and health systems have to work within financially rewards volume over value. Now we're having a few other options related to value-based care, but it's a little bit more complicated than it seems, and we'll see how things progress with that. There may be some opportunities to help people be healthier as compared to fee-for-service, but fee-for-service is still the predominant model. Reimbursement for behavioral education is very challenging. Some of those guidelines suggested a lot of contact time with the healthcare practitioner, much more than 7 or 8 minutes of a 15-minute appointment once in a while. So there are many strategies that are now being implemented more and more to deliver health education in a group shared medical appointment setting. And there are CPT codes that can be used to bill for this that CMS, Centers for Medicare and Medicaid, have approved, and many private insurance companies also approve. But the uptake of that is just starting, and it's more complicated in many ways to run group visits because you have to schedule around a lot of different people's schedules. You need your administrative support, recruiting, and making sure that everybody's going to show up because, of course, if you have 15 patients who are supposed to come to your group visit, and that's the minimum number the physician needs for it to be financially viable because of the amount they can bill for each patient, and only 8 patients come, you can't bill for those 7 patients that don't show up. At the same time, though, a lot of physicians, lifestyle medicine physicians and others are having success with shared medical appointments, and that is a path to be able to deliver the greater contact time that's necessary in health behavior education in a medical setting. Okay, moving on to this last point, the lack of training in medical education to incorporate lifestyle as part of treatment is really severe. And all of this, again, facilitates the use of pills and procedures as sort of the foundation of treatment. Nutrition education, particularly in medical schools, is lacking. US medical schools provide an average of 19.6 hours, so only 27% of them provide the minimum 25 hours that's recommended by the National Academy of Sciences. And physicians in training generally lack confidence and knowledge to address the underlying causes of chronic disease, so many of which are diet and lifestyle related. Only 14% of residents believe they possess the knowledge and training to provide nutrition counseling, and the majority do not really know guidelines for diagnosing and treating obesity. Less than 50% of residents feel confident in their knowledge of how to implement physical activity in their own lives, let alone how to prescribe it to their patients. And the graphic at the bottom is just a representation of some of the continuing, the undergraduate level, graduate, and continuing medical education programming that ACLM offers to try to fill this gap. It is a huge gap. And as nutrition professionals, I think it may be easy for you to forget that the healthcare professionals who are having those one-on-one conversations with patients and often are looked to as role models and educators around nutrition, physical activity, and other health behaviors actually don't feel very prepared, and really they haven't been very well prepared to have those conversations with patients. I wanted to give one example too of why it's difficult, the reimbursement for lifestyle education is difficult. The American Diabetes Association has a recommendation for the diabetes prevention program, and this was a specific intervention that was designed to prevent, help the prevention of prediabetes progressing to diabetes. It is covered by CMS with its own reimbursement structure as a clear program that can be implemented, but the uptake has been very limited because it's just not financially sustainable for the practices and health systems that might consider implementing it. So it's a 12-month program, and it's just not viable for the amount of time that is spent and the amount of money that is reimbursed to the physicians for patients that enroll. So these are some of the problems that lead to the fact that we know it's better to have healthier behaviors. We know that healthier behaviors leads to better health outcomes. We also know that it costs less for the nation and for individuals to be healthy as opposed to be sick. And we have a lot of clinical practice guidelines even recommending lifestyle, but there's a big disconnect between that knowledge and those recommendations and that being implemented in healthcare, mostly related to the lack of training, the lack of reimbursement, and the structure of these brief appointments that really are inadequate to be able to deliver the amount of education and contact needed. So to introduce lifestyle medicine, the American College of Lifestyle Medicine has a vision where lifestyle medicine is the foundation of health and all healthcare. And our mission is to advance evidence-based lifestyle medicine to treat, reverse, and prevent non-communicable chronic disease. We have a few specific goals: fill the gap in medical education, be a catalyst for change, eradicate chronic disease, and be ambassadors for health, hope, and healing. So that sounds a little bit lofty, but actually, I think that we all, I think the staff who work there really feel that. We feel a lot of passion for it, and we're definitely seeing a lot of change and uptake as things develop. And the lifestyle medicine focuses on 6 key domains of health behavior: nutrition, physical activity, sleep, stress management, social connection, and avoiding risky substances. We really kind of have a distinction between lifestyle medicine and alternative and complementary medicine, or integrative medicine, or some of the other medical specialties or fields of practice. We really just focus on the use of evidence-based health behaviors as the foundation of treatment. Our definition right now is that it's a medical specialty that uses therapeutic lifestyle interventions as a primary modality to treat chronic conditions, including but not limited to cardiovascular disease, diabetes, and obesity. And lifestyle medicine certified clinicians are trained to apply evidence-based whole person prescriptive lifestyle change to treat, and when used intensively, often reverse such conditions. So we focus on evidence-based medicine approach, high-value care that improves quality of life for patients, addressing the root causes of disease, and a team-based care model with patients as active partners. This is a nice graphic that kind of shows the intersection of medicine, science, and health. Lifestyle medicine touches primary care, which is composed mostly of internal medicine, family practice, pediatrics, and obstetrics and gynecology. Specialty care, meaning cardiology, endocrinology, neurology, preventive medicine, and oncology, and the sciences, epigenetics, microbiome, psychology, nutrition, aging, and public health. So because of the focus on 6 domains of health behavior, we really are able to kind of bring together a lot of fields that are more disparate than they should be, and when successful, can really treat people with a whole person health kind of approach. ACLM has some strategic areas. It's a very young organization. We were founded in 2004. We've had, I think, a 600 or 700% growth in membership over the last 6 years or so. There's a lot of excitement and passion among the members and the clinicians who are, as I mentioned earlier, possibly feeling burned out from conventional medicine and really looking to be able to help people achieve well-being, not just manage symptoms. So as a young organization, but one that's defining our field of practice, we want to define optimal practice frameworks and models with strategies for reimbursement, expand and deepen our educational offerings, and then really focus on including health equity, provider self-care, and chronic disease reversal as part of every medical conversation. And we need to do something now. So I really want to inspire you all to think about how you might want to engage in the field of lifestyle medicine. We have a lot of resources. We have a lot of members who are clinicians. This is a map of medical schools in light blue, bachelor programs, residency sites, lifestyle medicine interest groups, and master's and doctoral programs where I believe there may be one at Tufts, I can't remember, maybe in Tufts undergrad. And so we have a lot of activity within the academic space. We have clinical programs, a corporate roundtable, our health systems council, and there's a lot going on. So one kind of example of lifestyle medicine in practice would be a nutrition and physical activity prescription. And there's this could be another whole talk, but lifestyle medicine really focuses on treatment with a therapeutic dose of lifestyle change. So as opposed to taking, a low dose of aspirin to address a migraine headache, we know that's not enough, and it's not going to work. Similarly, making tiny changes in diet, physical activity, sleep, stress often produce results that are disappointing. And when you are doing like epidemiology and health research on a population scale, you often are comparing very small differences in exposures or behaviors from one group to another. And that is related to the small effect size that's often seen in that kind of research. When using lifestyle as treatment, the focus here really is on making big changes. People feel better very quickly. That's motivating for them to continue. And they often are able to achieve some outcomes that maybe have eluded them before. So as our Department of Research grows, like we have a lot of exciting projects going on right now. One is a patient chart review to review the feasibility and adverse events of patients with type 2 diabetes who've had lifestyle intervention and had medication deprescribed. We have another project, a qualitative study looking at the implementation of lifestyle medicine in health systems. And we have a lot of activity around developing more expert consensus statements in our first clinical practice guideline on type 2 diabetes. So the field is young, but what makes it really worthwhile to dig in and bring research methods in a rigorous way to this field is that so many clinicians report that with lifestyle prescriptions, such as what you're looking at right here, they really are able to achieve a lot of improvements that they were not able to achieve with medications. And that's kind of the work that I'm really excited to document, and I think we need more people to get involved and document. So just to give another bit of an overview, prevention, treatment, and reversal of chronic disease. Prevention kind of is composed of health promotion, principal care management, population health, and the annual well visit in a medical context. Treatment also includes principal care management, but disease management, chronic care management, and complex care management. Complex patients meaning patients with more than one condition. And then reversal heads into complex care management, like multi-system, intensive therapeutic lifestyle change, and cardiac rehab. Intensive cardiac rehab, such as the Dean Ornish program, is something that falls under this heading. And of course, that is one of the only lifestyle medicine programs that's covered by insurance. And that is really a great model for what we need to produce in the future to make sure that this kind of treatment is sustainable. So lifestyle medicine also targets the quintuple aim of better health, lower cost, patient satisfaction, provider satisfaction and well-being, and health equity. And it's kind of a big goal to have, but one that really, I think, brings together all the players that are part of the healthcare space and treatment. So proactive versus reactive care, addressing the root cause of disease, the continuum of care to prevent, treat, and reverse disease. Lower cost is very important to our nation. Patient satisfaction is extremely important for adherence to prescriptions, whether they be medications or lifestyle prescriptions. And patient empowerment is an important patient-centered outcome that's getting more attention now. Provider satisfaction and well-being is extremely important for preventing burnout. And health equity is a very important topic right now that fortunately is being woven into many areas of public health, research, and healthcare. And an important part of addressing health equity is making sure that lifestyle-based care and whole person care is accessible and affordable for all. So the field of lifestyle medicine and ACLM has a lot of different opportunities with corporate partners, health plans, ACOs, and health systems. We have a health systems council that's a volunteer, no-cost organization and network of health systems all over the country who come together for collaborative learning. The qualitative study that I mentioned is recruiting from within that network to understand the barriers and facilitators to growing lifestyle medicine programming within health systems. We now, actually, the slide is already out of date. We have over 90 health systems in the council, which is great, and a lot of different organizations. And, recently there was the White House Conference on Hunger, Nutrition, and Health. ACLM committed $22 million for 5.5 complementary hours of CME training. And we are doing our best to fill all of those spots for 100,000 physicians and other medical professionals. And we have so far achieved about 20,000, this says 12, but it's 20,000 that have enrolled. So this is a great path forward to reach a broad swath of healthcare professionals who went through the typical medical training and didn't really have a chance to think about nutrition, physical activity, and other lifestyle factors. And we just have a lot to do to kind of bridge that knowledge and the implementation in practice. You may have heard about the New York City Lifestyle Medicine Initiative with Mayor Eric Adams. So that's in partnership with ACLM, and we have lifestyle medicine training happening at a lot of different participating healthcare systems, and they have an amazing lifestyle medicine program citywide that is really going to transform healthcare in the city of New York. So a lot of exciting things are happening. one question that comes up, and it's very important for effectiveness research, is like, will anybody make substantial lifestyle changes? We know that some people will. How many? I don't know. We have to figure that out. That patient chart review that I mentioned we're doing right now is kind of a great first step for us in tracking what the proportion is of people who, as part of routine care, are presented with lifestyle change and a lifestyle treatment program. What's really strong about this project is that this practice, and they had about 600 patients with a diagnosis of type 2 diabetes. None of the people in this practice self-selected into a lifestyle medicine practice. They came to the practice as part of their routine care, or being assigned to the doctor whose practice it is. And from his estimates, and this is a study we're doing right now, so I don't have data to show yet, but from his estimates, about 10% were able to reduce or discontinue glucose-lowering medications. So that's not everybody, that's not even over half, but that's a lot on a population level. And that's something that is happening in a medical office with one or two practitioners. And that's something that could be replicated if other healthcare practitioners and physicians are aware that this is possible and able to administer this kind of treatment to patients, even when they, we're not seeking it out. So to conclude, we really need you. The field of lifestyle medicine needs researchers, clinicians, and policymakers. I really urge you to consider getting involved. And I think there are three kind of paths to do that. You could partner with a lifestyle medicine clinician to conduct cross-sectional research, run an intervention, conduct a retrospective record review. There are so many clinicians in our membership who have very exciting data and patient outcomes. We have a lot of clinicians who do not have experience in research, do not have the time to become a researcher. They already have a job. They are very busy, but they're getting incredible outcomes with patients that really need to be quantified, published, and eventually, we need to run larger trials with some of these interventions to test their efficacy and effectiveness. So I would encourage, all the students and faculty who are kind of looking for maybe a setting to run an intervention, help with recruitment, a possible data set, although it really depends on the question you have, but we would really like to make available relationships and connections between clinicians and researchers so that all of this great opportunity to study the health outcomes and the improved patient satisfaction and the clinician well-being, all of these things that we're starting to record and quantify ourselves and also hearing anecdotally from our members can be studied. I know that recruitment is tough in research, and a lot of these health systems have a patient population ready to go. They have a site. They're probably doing some kind of intervention that would be a good intervention to study. So please consider that. Then for those of you planning to go in a clinical direction, explore lifestyle medicine when you become a clinician. We have a lot of members who are students, residents, postdocs, and other graduate level students. And then finally, for those of you heading into policy and education, think about incorporating lifestyle change reimbursement in policy work. This is one of the biggest barriers to actually translating the information that we know from public health research into medical practice. And there's just a lot to do here. So the more kind of attention we have on this space, I think the better and the faster we can work together to be the change we wish to see in the world. So thank you, and I'm happy to take any questions.
Thank you, Micaela, and very proud to have you here to give the talk and very nice presentation and introduce the lifestyle medicine to us. Let's give a round of applause to Micaela. Thank you, Micaela. Questions? Any question in the chat? Let's see there.
Well, I see a lot of really nice messages from people in the chat, so thank you for your thoughts. It's been fun to be able to share this, and yeah, there were a lot of other. I guess there was a lot of information I left out. I wasn't able to present a lot of the patient outcomes that we're now starting to publish, but yeah, tried to pack in a lot, I guess, in the time.
Right. So actually, I'm trying to. I want to ask that, like, when like the people using the lifestyle medicine as a prevention or either tertiary, secondary prevention, how you monitor the adherence and evaluate those whether people can change their goal or not.
Yeah, I mean, I think that's why there is so much work that needs to be done in partnership with researchers. We just submitted revisions for a case series of around 60 patients who were patients of an Ornish clinic. So this is the Ornish Lifestyle Heart Program. So they were cardiac patients, but also had type 2 diabetes. And the physician, their primary physician in the program assembled the list of patients that were extremely adherent and were successful in making substantial lifestyle changes and were able to either reduce or discontinue all medications. So with the definition of remission that we published, which is 3 months of normal blood glucose and no medications and no surgery, about 30% of those patients achieved remission. And, the others made some substantial gains. Like some of them changed from insulin to metformin, which is a lot less intense and less expensive. So those were his success stories. That was the list. It was a case series of success stories. But it just shows that, it is feasible for some people. And his assessment of their adherence was based on his conversations with them when he would meet with them. So I think we need, like, one gap that we have is more systematic ways of characterizing adherence. And we also need to really characterize what prescriptions were given. So we have a lot of work right now to recommend some custom changes in, like, Epic is one of the major electronic medical record systems. And there isn't really currently a systematic way to capture what the lifestyle medicine prescription or advice or recommendation really was. But I think as that becomes possible in EMRs, then that will be something that in the future we can draw from. But yeah, in the immediate term, like, I think that needs to be assessed separately, and also the factors that can help you predict whether people will be successful.
Okay, great. Alex, you have a question?
Hi, really interesting talk. Thank you. Building on the part about adherence, I'm curious about what whether there's pieces of these interventions that are geared toward trying to help patients overcome barriers, whether it's, all of these chronic conditions that everyone has, or economic conditions where they might not have time to cook or to exercise, and how ACLM is approaching that.
So I guess your question is, do we have recommendations for how to overcome, like, personal and socioeconomic barriers to just making healthy changes?
Well, I don't know if it's recommendations or things that could be done through prescription or other means that would help patients to overcome those barriers.
Yeah, well, I did talk about the shared medical appointments earlier, and that's been like a huge asset to the field of lifestyle medicine. And behavioral medicine. And COVID-19 really kind of accelerated the reimbursement for telemedicine and shared medical appointments in a telemedicine format too. So that's all been very positive because we know that social support for healthy behaviors is predictive of like maintenance of healthy behaviors and adoption of them. And so a lot of successful group medical appointment models have like between 10 and 20 patients per visit. And they do seem to be, there does seem to be like an added, even in a virtual setting, although in-person works better than virtual, but in both settings, like the outcomes that have been published about shared medical appointments really speak to the, I guess, additional benefit and support from having the social interactions, coming together to talk about their health problems and their goals, and also going through the education together and possibly doing goal setting together. And then sometimes being able to meet outside of the group with the physician. So I think that, you know, like that's possible. We've actually had a few presentations on shared medical appointment models at our conference. And there was one also from a nurse practitioner in New York City who did use a virtual format. So this was during COVID. And she was working at an FQHC, so a federally qualified health center. So it was a population that definitely had some economic challenges, but she was able to get like 30 to 40 people per group visit. She started very small and she created programs that were based on suggestions and requests from her patients, and she only developed content based on what they asked for. So eventually she had like a list of 20 or 25 different 1-hour classes. She would hold them during weekdays, and she would get really good attendance and had really good feedback from the patients about their experience and how it helped them, even though it wasn't in person. So yeah, I mean, the barriers to healthy behaviors are very real for many people. But I think even in some historically disadvantaged communities and settings, low resource settings, like the shared medical appointment model is something that does seem to be helping on more than one level, not just for the financial viability of having the patient contact time, but also just like coming together for the patients has a lot of, you know, support benefits for their adherence.
We start late. We have 1-2 minutes for very short questions. So Yutong, you have questions? Go ahead.
Yeah, I have a very short question. So thank you for the presentation first. And then in your presentation, you showed like a butterfly graph to categorize the guidelines into most encouraged food group and the most discouraged food groups. So for that one, I'm just kind of curious what kind of guidelines you were included in the analysis, and then what are the target population for those guidelines? Are those target population like a general health population, or are those like guideline designed for like chronic disease population, something like that?
Yeah, so the vast majority of them were populations with a specific chronic disease condition. I think only one was aimed at general health promotion, and we excluded guidelines that were aimed at children only. And so these were all focused on adults. And Kelly, who's the first author, is here. And Kelly, I'm happy if you want to add anything about that.
It's all correct. We did look for general population CPGs or clinical practice guidelines, but we ended up refining that one. These were documents aimed at clinicians, not documents that were aimed at lay people. So these were professional documents meant to be guidelines in clinical settings.
Okay, got it. Thank you.
Great, thank you so much, Micaela. Very nice to see you. Although it's virtually, hopefully I will see you next week in person.